Prevention of ovarian carcinoma. Use of OCP has been associated with a significant reduction in the risk of ovarian cancer. Specifically, risk has been decreased by 10 to 12% after 1 year usage of OCP, and approximately 50% decrease after the use of 5 years. And follow-up analysis of CASH data. What was CASH? Cancer and steroid hormone group data has indicated that formulation with high level of progestin are associated with a lower risk of ovarian cancer. High level of progestin, they are associated with lower risk of ovarian cancer. The steroid hormones and reproduction share study was noteworthy for finding no difference in ovarian cancer risk between androgenic and non-androgenic pills. Women harboring germline BRCA1 and BRCA2 mutation have also benefited from a reduction in the risk of ovarian cancer through OCP use. So first one is OCP for the prevention of the ovarian cancer. Risk decrease 10 to 12% after the 1 year use, and 50% decrease by the age if used for 5 years. And progestin only contraceptive pills also reduces the risk. Then risk reducing salpingo-oophorectomy that should be considered for women with a germline BRCA1 and BRCA2 BRIT1 mutation. Women with a strong family history of either ovarian or breast cancer who have not undergone genetic testing may carry a deleterious mutation and can be presumed to be a higher risk than average risk. And this woman should also consider RRSO, which may also reduce the risk of breast cancer by 30% to 75%. And in most situations, RRSO is typically deferred until the age of 35 years or when childbearing has been completed, if that occurs sooner. Finally, it has been estimated that approximately 15% of the patients with Lynch syndrome, they are at risk for ovarian cancer. These patients also have a lifetime risk of 60% for developing endometrial cancer. Therefore, risk reducing surgery include hysterectomy. And due to microscopic arrest of residual ovary, occurred pre-existing carcinomatosis at the time of prophylactic surgery and or multifocal origin of peritoneal tissue after RRSO, the risk of developing serious carcinoma of the peritoneum has been reported in the range of 1.7 to 4.3%. So the technique of RRSO and pathological processing include bilateral salpingo-oophorectomy with the removal of the entire fallopian tube, cytological examination of the peritoneal washing, random peritoneal omental biopsies along with biopsy of any suspicious lesion, serial sectioning of the entire fallopian tube and ovaries at 2 mm intervals, and microscopic examination of all sections. GOG Protocol 0199 is a non-randomized trial enrolled women at high risk of developing ovarian cancer BRCA1-2 mutation with a strong family history, designed to compare RRSO at enrollment with serial transvaginal ultrasound and CA125 screening ROCA. All enrolled patients had a baseline CA125 and a transvaginal ultrasound performed, and then choose to have either RRSO or continue screen every 3 months interval with the ROCA evaluation. Pathological review of 966 prophylactic surgical specimens found 4 pre-invasive tubal cancer and 20 invasive pelvic cancer involving exclusively ovary, fallopian tube or inner peritoneal lining of the body. And this pelvic cancer, only 12 were detected microscopically, but all 20 cancers, they were serous carcinomas. Overall, the prevalence of serous pelvic cancer in this asymptomatic woman with BRCA1-2 mutation was 3.2% as compared to 0.5% among patients who did not have BRCA1-2 mutation but had a strong family history of breast or ovarian cancer. And interestingly, a 515 patient had their uterus removed at the time of removal of the ovaries, and 6 endometrial cancer were also found.